Good, good afternoon. I am Walt Bauer, and I'd like to welcome you to the Human Development Institute's second fall webinar. We welcome all the participants who are joining us online. Our presenter will provide an opportunity for questions this afternoon, and we welcome questions from all of our participants. Please type your questions for our presenter in the Q&A box. Please use the chat box for technical questions. You are joining the webinar on mute and without video. We have live captioning for this webinar this afternoon. To turn on the captioning, click the closed caption button at the bottom of your screen and then click Show Subtitle. Please take a moment at the conclusion of the webinar to complete our brief evaluation. The evaluation will be sent to your email address after the webinar. It is really helpful as we plan for upcoming webinars. Should you have questions about CEUs, you can contact me. My name is Walt Bauer, and you can contact me at my email address. It is walt.bauer@uky.edu, and I'll give that again. That is Walt, W-A-L-T, Bauer, B-O-W-E-R, @uky.edu. The title is The Role of Ableism in Perpetuating Healthcare Inequities. Our presenter is Dr. Kara Ayers. Dr. Ayers is the Associate Director and Assistant Professor at the University of Cincinnati Center for Excellence in Developmental Disabilities. She is the Director of the Center for Dignity in Healthcare for People with Disabilities and also co-founder of the Disabled Parenting Project. It is a pleasure and a privilege for us to have Dr. Ayers with us here this afternoon. I'm now going to turn it over to Dr. Ayers. As we say, the floor is yours.
Thank you so much, Walt. It is my honor to be here today, not only to join this series. I always enjoy the opportunity to work with our neighboring UCED and from my home state of Kentucky as well. But this topic is so important, and I'm really appreciative of you all for joining me on this Friday afternoon in our time zone, at least, to spend some time thinking about and talking about these really important issues. So thank you for that. This is a picture of me. I'm seated in my wheelchair and have my service dog, Rocky, with his legs across my lap. We were just matched in February. I usually use this slide to remind people that in this case, I don't have any conflicts of interest in making this presentation to disclose to you. But also, I think it is a reminder of our move to virtual and kind of tele everything, in that for the vast majority of my life, whenever I have entered a room or a physical space, it's become pretty immediately apparent that I have a disability. So disclosure or sharing that hasn't always been something that I've needed to do in most cases. But in thinking about today's topic in healthcare, I'm reminded that for quite some time I have had to, in making my own appointments and advocating for my own healthcare, disclose that before I actually entered the healthcare setting. So I wanted to share that I come at this from a few different perspectives. So I am trained as a psychologist, so I bring that background, and increasingly this focus on healthcare inequities has been an area of research for me in the last few years that I've looked at from many different angles. But also personally, I'm a disabled woman and as well a family member and parent of people with disabilities. So a few kind of quick notes on language throughout this presentation. So you'll hear me use identity first and people first language interchangeably. I tend to use people first mostly in professional presentations like this, but for my own identity, I identify as a proud disabled woman. So both kind of in all variations of language in this way are valid. Back to my connection to disability, as having a visible disability, I've noticed the way that healthcare providers can make assumptions about my life and what it must be like, and how that can play a role in their recommendations for my healthcare. Most recently, a couple of examples, I broke my hip about 6 weeks after I had my youngest daughter. So I have a disability called osteogenesis imperfecta, or OI for short, and one of the primary characteristics of our disability is that our bones break easier than most. So I had fallen from my wheelchair and broken my hip pretty badly. And in meeting with a new surgeon, as we were kind of coming up with a plan for how we were going to piece me back together, his first two suggestions were, well, we can just fuse this joint so that we'll just put it back together. It won't move anymore, but you'll need to figure out, do you want to be fused seating or laying down? And he kind of wanted this rush decision, and indicated that his assumptions about my life were that it was kind of 50-50, didn't much, matter anyways, because there was definitely an assumption that I must not be very active in my everyday life. So luckily, I was at that point in my life pretty well versed in advocating for myself, although it's never easy, no matter if you have the privilege to do this as your profession as well. So I explained to him, why that wouldn't work. While I use a wheelchair full time, there are many parts of my life that that I do need to stand and transfer, and laying down was going to be an option, and what else, could we look at? And I really realized that I had to paint a picture of my life so that he understood it, but in doing so, I also needed to correct, the painting that he already had in mind, which was much different from my reality. Another example, much earlier in my life and earlier in my ability to advocate for myself and kind of untangle people's judgments about disability versus providers' medical advice or clinical recommendations. So I had sought a genetic counseling consultation appointment to learn more about my specific genetic mutation that causes my disability, and also some of the questions that I had brought related to what would the prospect of parenthood be for me? So what percentages could I expect that I would or wouldn't pass on my mutation? And if I did, what might severity look like? Those types of questions. So when I got my information, there was a resident in training, and after the meeting he shared that he would encourage me to adopt. So I thought that was a strange recommendation at the time, but again, much earlier in my advocacy experience, so didn't really know what to make of that. And as I asked him more questions, and especially as I reflect back today, it was clear that his recommendation was more based on his personal belief that people with genetic disabilities should not pursue biological parenthood. And again, it was his reality was so much different than my own that he couldn't imagine why anyone would pursue that. So interestingly, I did adopt, but I also have two biological children. And, one of my three children has a disability, and I also see variations in healthcare for him in terms of assumptions that are made about his life, and already having that responsibility to clear up inaccuracies of the paintings that other people make of our realities with a disability. And so I'm trying to help him with that, do that for him while I can, but also arm him with the tools necessary to untangle when someone's making a decision or prompting you to make a decision about your health care that is more about their beliefs about your life than it is about their medical knowledge or their expertise or what would be in your best interest. So a little background, or a little forward thinking this time. Webinar objectives. So I have high hopes for us in the next couple of hours, and I think we can do it. So by the end of this webinar, I hope that we'll be able to identify some areas and expertise or areas and experiences in healthcare where there seems to be a high frequency of inequitable treatment of individuals with disabilities. I want to make note that this is going to be a higher level scan of some kind of specialty or niche areas. And some of these might seem sort of rare to you. We're going to be talking about organ transplantation as one example. But we've also honed in on these specific areas because they have such life-limiting potential, unfortunately. So these are kind of the areas where all of these inequities coalesce and become more than just annoying or unfair, but we get through them, but could actually result in loss of life or shortening of life based on discrimination. So there has been some deep thought in terms of which of the 4 issues we're going to focus in on later in this presentation. But I want to recognize that, inherently we're not going to capture some of the more general but very harmful everyday instances of inequitable treatment. So things like, doctors' offices that are inaccessible, poor communication from provider to patient, in some cases, no communication options. Sometimes there are elements of these in the topic areas that we'll discuss today, but I just want to recognize on the start of this that we know that these are just as problematic. Another note on language that you might catch with my discussion today is I'll flip back and forth in saying we and our, and that really recognizes what a collaborative effort a lot of the work that I'm going to describe to you today involves. So I really think about it in my head more as a we and our situation or effort, because it is definitely not me. I'm thankful and honored to be able to tell you about it today and share it with you, but I'm just part of the overall effort and your messenger today. So other objectives I hope we accomplish, we're going to recognize some strategies aimed to address these inequities. So I always get a little frustrated myself when we just identify what needs to be done, but don't start the work of recognizing the how behind it. How can we address these? And we're also going to discuss the role of professionals and advocates in seeking disability justice in healthcare. So to get us started, it's important that we talk about what is ableism. So ableism is a form of discrimination. It's another ism, but this one is the idea that non-disabled people are seen and treated as superior to people with disabilities. So it's really that assumption that people with disabilities in and of themselves and because of disability are devalued. And so ableism is a set of beliefs or practices that do that devaluing and discriminating against people with disabilities. We can see ableism in behaviors. We can sometimes hear it in the words that people say or the way that people say things. And it can be really hard to point out ableism because it's built into our society. I sometimes use the metaphor of smog as a representation of ableism, because in this case, in this slide, we can see the smog is billowing from the plumes of where it's created. But you can imagine that, a couple miles out from this plume, the smog is still present in our environment, but you cannot see it as clearly. And so it's harder to point out. And others, when you do point it out, can say, I don't see any smog there. What are you talking about? And that is similar to ableism in that we're still breathing it in. We're still experiencing the negative repercussions of ableism. But as it becomes more covert and kind of undercover, it's that much more difficult to point out. There's also a level of defensiveness in that no one wants to be called out for discriminating against others, and it can be difficult to make that call out too. So I think it's, the pervasiveness of smog is an interesting comparison because it can cause us real harm, but it's also not something that we can kind of put our hands around and grab. Ableism is also the notion that the disabled mind and body are broken and need to be fixed. And so in this image, we have a very clearly visibly broken pencil. That is the first thing that many people would see with this image. But on the other end of that pencil is a very sharp and functional lead. And so I thought this image was a good representation of kind of the two ends of the spectrum that many people with disabilities view their life. So they feel that in their life, they feel like they've got that sharpened pencil point working pretty well. But in the healthcare system, it can sometimes feel like providers and others in that space only see the broken edge on the other side and are only looking to fix that broken edge. So ableism can take many, many forms, including but not limited to failure to comply with disability rights laws. So that is where it comes into play, the inaccessibility of physicians' offices, segregation, so separation of healthcare resources and programs, And some would even argue that some of the way that we approach clinical trials is segregation, in that there are research-based reasons that we exclude populations from studies, but as a result of that, many people with disabilities are excluded from the vast majority of clinical trials. So when we get results from studies that say that, this treatment or this drug worked on X percentage of people, we can't ever be sure if it included people like us. So segregation can take place in kind of different forms in the healthcare system as well. Also, a lack of representation from the disability community in decision making. One of the strategies that we'll address at the end today that I hope will be a bit of homework you'll be motivated to do will be to find out in your home hospital or home healthcare institution, on your ethics committees, or sometimes there's community councils or other groups in these healthcare settings that make decisions, is there a representative from the disability community? In many cases, ethics committees have requirements or set their own expectations to have representatives from faith communities, from different backgrounds in the community, so that the makeup of their decision-making body looks a lot like the people that live in that area. But in most cases, a representative from the disability community is not included, despite the fact that, as we've especially seen during COVID-19 decision-making, there's a lot of disability relevant and specific aspects of making these decisions. So that lack of representation, unfortunately, can result in ableism in itself. Another form of ableism is eugenics, and that's probably the heaviest loaded word, right? The idea that kind of purifying the gene pool to eliminate disability is what eugenics is typically defined as, but it can happen in more covert ways as well. So at the start, when I mentioned the example of the resident who discouraged me from considering biological parenthood, based on his belief that those with a genetic disability should not be biological parents, that can trickle down to other forms. With my work with the Disabled Parenting Project, my colleagues and I wrote a comment back to Pediatrics, the journal, a couple of years ago, because they had made a pretty widespread, generalized recommendation in a publication about suppressing the menstruation cycles of adolescent girls with intellectual disabilities. And so the purpose of the article was to reduce some of the negative side effects of managing menstruation when you have a disability, but there was no mention in the article that this would also suppress the options to pursue parenthood down the road for these young women. So there was definitely an assumption baked into this article that was published without any type of concern, I guess, from the peer reviewers, that individuals with intellectual disabilities should not pursue parenthood, and therefore medical interventions that would make that impossible are not seen as ethically problematic in any way. So this is another form of ableism that takes place in our healthcare systems that we need to watch for. So ableism in healthcare can be implicit, meaning that it's under the surface. It's hard to see. So microaggressions. I know I've definitely experienced myself, but more recently with my son, who is 13, where his disability, he is smaller than his peers, and so I have noticed sometimes healthcare providers will talk in more baby-like voice than I'm pretty sure they would other teenagers. So that implicit kind of microaggression interaction in healthcare can be problematic. Explicit forms of ableism in healthcare can be found in use of outdated language, or again, that type of medical advice. It's framed as advice, but it's based more on personal biased beliefs about disability. So I always caution people that when your advice from a medical professional seems more like, what they might tell you as a random person in the store or as a neighbor or something, then that's concerning. And sometimes we need to be more actively in search of what exactly clinical or scientific evidence they're using to back up their advice to us, because we can't always presume that that's the driving force. Internalized ableism is the idea that, so remember the smog example with ableism. So even though I am a person with a disability, I still am breathing in negative messages about disability often. And this can cause us as members of the disability community to get pitted against each other. We can devalue our own lives. We can create and reinforce hierarchies. So the idea that, well, I deserve optimal health care, but if someone else has a different disability, then it's understandable that resources wouldn't, be allocated to them in the same way. We'll talk more about how all of this has come into play with COVID-19, but as an example that I'm concerned about with COVID-19 and rationing is some hospitals piloted some decision-making tools with patients where they actually asked patients as they were admitted to the hospital, they said, should we encounter a shortage of nursing staff or ventilators or whatever it is, would you be willing to kind of go to the back of the line and not take resources? And while I guess that approach, it circumvents the idea that a committee or another person are going to make those decisions anyways if we get in that awful position, it's very problematic due to internalized ableism, because many of us with disabilities already devalue our lives in some way, whether big ways or small ways. And so to ask a group of individuals that are part of an oppressed party or a marginalized group, no matter what that group may be, if kind of they want to give up what they need for others, is in some ways an unfair question, because we've already received so many messages from society that we don't deserve, we don't need it as much as others. So it's one of those tricky things that internalized ableism can really sneak in. And last in the types of ableism that I've listed, and there are many others I've tried to rein myself in on only giving you 4. The fourth one is systemic or institutional ableism. So again, that example of having no representation of people with disabilities among ethics committee members is problematic, but also when you don't have any disability representation among your providers or your staff, that also lends a different perspective in treating our community. Other examples of systemic or institutional ableism are policies or rules within the hospital that just don't consider disability-related needs. And those can sometimes be a little strange in my experience. Things like you have to leave mobility equipment outside the exam room because we don't have enough room in there if we have your wheelchair, which, I can't imagine anyone else wanting to be kind of like on an island of the exam table with no way out. So sometimes they can feel strange to us, but that's also because we have that disability-related experience. So these are just the 4 kind of buckets that I've classified ableism. I wanted to take a minute for some interaction, and I forgot to give you a heads up that we're going to, I hope to have some engagement across this talk. So we're going to have a chance for questions in a few minutes. So I'm going to have 2 questions time. So one in sort of the middle of our talk and then one at the end, so that hopefully you don't have to hold them too long. And I do really encourage you to add questions to that Q&A box. That will make this more meaningful for you and also interactive for all of us. But first, our first opportunity for interaction. So take a moment to add to our chat box an example of ableism in healthcare that you have either experienced or observed. And if you want to, some bonus points for our non-graded assignment here, take a shot at attaching one of these types of ableism. So as an example, you could put something like implicit and then dash provider speaks to my non-disabled friend or spouse during my appointment instead of me. So many people have experienced that. And I guess you could argue that that's implicit or explicit, but there's no right or wrong answer here. So I'm going to take a look in the chat box as these come in to see some examples. We've got some good examples coming in already. Doctors kind of proceeding with procedures without telling the patient what to expect, not giving them that dignity of knowing that something's going to be painful if it is. Definitely systemic clinics without high-low adjustable tables for transfer independence. And it's interesting the amount of labor that those of us, who are advocating for this, but also in making our own appointments. I mean, I know that's a question that I ask if I'm going to a new office is, do they have the adjustable tables? And the number of things that we kind of have to keep in our head to ask about is labor in itself. Explicit, taking someone to the doctor and the doctor speaks to me instead of the person being seen. I agree that could fall under explicit. Yeah, many of the protocols for COVID have been systemic and institutional, have been examples of that type of ableism. And they've also been, when you read it, it's pretty explicit in terms of rationing care away from people with disabilities with really no other consideration other than just their diagnosis. All right, we've got some great examples here. I see examples of explicit ableism in urgent care doctors turning away people because kind of they've decided that they're going to be uncooperative despite exhibiting no behaviors indicating that in the waiting room. And just kind of the idea that we are under evaluation about whether we deserve care or are going to get care versus other people kind of have that assumption that they'll work it out. Oh gosh, I'm really behind. So there are some really great examples. So one example is showing videos in class that are audio only. And we'll talk a little bit later too about the intersection between doctors with disabilities or providers with disabilities and maybe what they could bring to this discussion as well. But in many cases, they reflect on the medical training that they receive to be a healthcare provider as being pretty ableist in some ways. All right, so I hope you're also taking a look in that chat box. Sorry, I'm a slow chat reader, but there's so many examples. So this assumption that if a client uses a wheelchair, so that using a wheelchair means that they do not produce speech. Yeah. Okay, so many good examples. Thank you all for engaging in that. I guess they're not good examples, but they are indicating that we're seeing this in our healthcare experiences or we've heard about it. All right, so next let me move us. All right, so we shared some examples of ableism, and next up, I want to see, all right, which of these four, all right, so hopefully you can see this poll. So next up, we're going to try a poll. Which of these four types of ableism do you think is easiest to address? So implicit ableism, explicit ableism, internalized ableism, and then systemic or institutional ableism. I'm seeing the votes come in. All right, we'll give it another 15 seconds or so. Okay. So you can see that most of you thought that explicit ableism was the easiest to address. And maybe that's because, it's that smog at the front of the plume where we can see it, we can point to it, and that in itself makes it easier to address at times. All right, but we can see that there's some definitely others as well. All right, so we've got another poll question for you. Ooh. So which of these 4 types of ableism do you think is hardest to address? Oh, you all are quicker voters this time. All right, we'll give it another 15 seconds or so. Okay, so this was a close one. So it looks like most people felt that systemic or institutional ableism was the hardest to address, but interestingly that internalized ableism came up pretty high as well. And I think that's probably how I might rate these two as well. The internalized ableism can be hard to catch even when you're looking for it. All right, one more poll question for this segment. So which do you think is the most important to address of those 4? All right, we'll do 10 more seconds, although it looks pretty set. All right. So here's our results for that one. 67% of you felt that systemic or institutional ableism was most important to address, and then it's pretty evenly split across the other 3 that many of you still felt like those were priorities, which I totally agree. So yeah, we have a big challenge ahead of us in that this is one of the more challenging types of ableism to address, but definitely very important. And so I hope that today you'll be able to apply much of what we talk about to that mountain that we all need to climb. Right. Thank you guys for engaging in that. That was actually my first attempt at launching polls, so it went really